we've been dispatched to a 60-year-old male who has collapsed on the sidewalk. It's a suspected cardiac arrest. Before we approach the scene, we want to ensure that my All-Sider and I are wearing our correct PPE, so our gloves and our glasses. We also want to assess for any possible dangers or hazards that could pose a potential harm to myself, my All-Sider, or the patient. First glance at my patient, I can see that he is supine on the ground. He appears pale and grey, does not appear alert to our presence. I can see no signs of respiratory effort, and I can't see any obvious signs of blood or deformities. Are you happy to enter? Yes. Sweet. Hello, sir. My name is Karli. I'm a student paramedic. Can you hear me? There's no response to voice. I've checked for a pain response. So I'm just going to squeeze your tibia. Let me know if you can feel any pain. So no response to pain. I'm going to check the airway. I can see no signs of occlusion, so the airway is clear. I'm going to look, listen, and feel for breathing for around 10 seconds. Feeling for breath on my ear, looking and listening for chest rise and pull. 10. So patient's not breathing. I'm going to immediately start compressions. Alice, can you attach the pads, turn on the monitor to manual mode, and charge to a maximum adult dose of 150. Can you also update comms that we have a confirmed R49 and request for an R50?
81 comms.
When this is fully charged, we're going to analyse the rhythm and determine if we need to shock or not. So we're going to analyse in 3, 2, 1. We're in VF, so we're going to shock, clear, back on the chest. Alice, can you secure the airway with an LMA, attach it to a bag valve mask and oxygen at a flow rate of 15 litres per minute? And let me know when you've done this so we can assess chest rise and fall. So our first shock was at around 20 seconds. Our second shock will be, we'll analyse the rhythm and determine if we need to shock at 2 minutes and 20 seconds.
Amazing.
Sweet, check the chest rise, 3, 2, 1, go. Good chest rise and fall. So Alice, can you secure the LMA? Put the filter onto the LMA first, followed by the end-tidal CO2 and the COBS connector, and let me know when you've done this. At this time, we can ask any bystanders if they witness the collapse, if they know the patient, know his medical history, or if he's on any medications, or if they know what he was doing prior. Once you've secured the LMA, Alice, we'll go to continuous compressions and ventilate at every 10 or at every 6 seconds. So I'll get you to count my compressions out loud.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
At 2 minutes, Alice, I'll get you to push charge, and you can come around to my right side. We will then analyse the rhythm, determine if we need to shock, and swap positions. Push charge. Come around to my right side. Don't start compressions, but take over from me. 1, 2, 3, 4, 5. Analysing the rhythm, we're still in VF. We're going to shock, stay clear, back on the chest. Count your compressions out loud from 10 for me, please. So that we have our ABCs under control, we can start to look at any possible reversible causes, such as our H's and our T's. So for hypovolemia or trauma, we could do a rapid trauma suite. However, this would be preferable when backup arrives to minimise time off the chest. So I can't see any obvious signs of deformities or significant blood loss. However, we can't rule out internal bleeding. We are currently unable to assess hydrogen ion acidosis, hyper or hypokalemia, toxins, tamponade, or thrombus pre-hospitally. For hypoxia, we're doing our best to reverse this with our adequate ventilations and monitoring our chest rise and fall. For tension pneumothorax, we don't suspect this as we have equal bilateral chest rise and there's little resistance on the bag valve mask. Hypothermia, our patient was warm to touch and we're not in an extremely cold environment, we're actually in a fairly warm environment, so we're not worried about this. Hypoglycemia is something that we can check if we get ROSC, so we can take a BGL of the patient. How are you feeling, Alice?
10. Right.
So, as our last shot was at 2 minutes 20, we're going to do our next shot at 4 minutes 20. At 4 minutes, I will push charge, and I will come round to your right side, and we will analyse the rhythms, determine if we need to shock and swap positions.
7, 8, 9, 10.
Charging, and I'm coming round.
6, 10.
Good. 5, 4, 3, 2, 1. We're in asystole, which is not shockable. We're going to disarm, Alice. Back on the chest. We'll do another 2-minute cycle, counting out my compressions, and then we will reassess the patient at this time.
7, 8, 9, 10.